All right, welcome back, everybody, for our 10:45 session titled Surveillance Post-Treatment: What to Expect with the Wonderful Dr. Carmona. Dr. Carmona completed medical school, internal medicine, and medical oncology residencies at the National Autonomous University of Mexico. After this, he did a 3-year fellowship in gastrointestinal and breast cancers at the University of Toronto Audet Cancer Center. Dr. Carmona holds a Master of Science in Molecular Biomedicine and a doctoral in clinical trials and methodology from the National Cancer Institute, where he designed one of the earliest investigator-initiated trials that provided evidence of the feasibility and efficacy, of the chemo immunotherapy approach. His clinical and research interests are to improve, create practical evidence in GI and breast malignancies that reflect which treatments are the best in a real world setting. In this context, he strives to develop trials that generate impactful real world evidence to optimize treatment strategies for patients living with GI and breast cancers. We are absolutely honored to have you with us here today, Dr. Carmona, and I'm thrilled to pass you the virtual floor.
Thank you so much, Christopher, and thank you so much for you being here. Hi, Filomena, how are you doing? I'm really thrilled to be here. Thank you so much for being here, for being part of these huge CRN commitment, and a shout out to all the people making this happen. I know it's not easy, and it takes a lot of work, a lot of resources, and having all of this to support patients. I think that we are really, really grateful to have, and I'm honored to be able to be here today. So as I was saying, like I have basically for my talk today, I have a dual purpose. So, in my practice at the Odette Cancer Center, and specifically with our familial and high risk GI clinic here in Toronto, because we just opened that up, just a little bit of promotion. I emphasize always that surveillance is not a passive phase; it is a proactive strategy with two goals: early detection and managing late side effects. So with that in mind, I'm going to share my screen. Just wait me a second. Sometimes I struggle with this. I'm sorry. So, okay, please let me know if you can see my screen. Should be a slide. Okay, perfect. So that's me. My name is Carlos. My last name is Carmona. I'm one of the breast and gastrointestinal oncologists at Sonneberg. I'm also part of the cancer genetics and high risk program, and I'm part of the University of Toronto as an assistant professor. For this talk, I don't have any disclosure that can affect whatever I'm going to say, so I'm really free on to say whatever I want here, and obviously to answer any questions you may have. So the way I see like moving into this phase of the journey, which I always call like this transition or crossing the finish line. So the active treatment, either it was surgery, chemo, in some case radiation, has completed. Okay, so you're done with that. And here the shift from frequent medical contact, because remember, uh, our patients are undergoing chemotherapy and treatment and so on. You actually see us a lot. And actually, I always make this joke with my patients is like, you get to get rid of me for a few months at least and go back to your life. And I'm always happy about it because the less you need your oncologist, the better you are in general terms. So, and I always have to acknowledge the emotional weight of that, what it's called or has been framed as scanxiety, which is basically being anxious about what the next um what the next CT scan, what the next colonoscopy, what the next blood work, what the next biomarker will show up. Okay. And, but I always remind my patients that surveillance is not passive, it's an active phase of care. And also surveillance, even if we're going to talk about what are like kind of the standard times when and what are the components of the usual surveillance. This can be also taken as just a general guidance. Like it's it's not one size fits all. We modify it depending on the perceived risk of our patients, whether they have higher risk, lower risk, or if there's any symptom that is coming that we cannot explain and it's not getting better. I always phrase it to my patients in the sense of if you're having a symptom that after a couple weeks, 2, 3 weeks, it's not getting better, that's when you have to let me know. And I don't have to wait until that point in time that you were booked for your CT scan. And because I always explain, like, we all can have back pain, we all can have abdominal pain here and there, but usually should go away within like a few hours, a few minutes. But if it's not like doing that, then something we have to also acknowledge that part of the surveillance is that our patients are active part of it. Like we rely heavily on you guys always trying to let us know as soon as you are feeling something or you're having any symptom. If you let us know, that will always make things easy. Like it will be easier for everyone to catch whatever we have to catch in an early phase. So then why we're doing all these surveillance and as I was saying, it's a proactive strategy with two goals. First of all, we want to have that early detection. And that early detection could be catching microscopic isolated recurrence, liver or lungs, because compared with other subtypes of cancer, we have evidence that if in colorectal cancer, we do find the disease early enough for it to be resected again, we can potentially cure a good proportion of our patients. Depending on the series or the data that we are looking at, that can be as high as 50% of the patients will be cured by just undergoing another surgery again. Okay, so that's why we are trying to do that. And I'm going to talk later on in this setting about like new technologies to catch really microscopic recurrences and what to do with that because at this point there is like not too much guidance on what we can do, and probably you already have heard or in the prior talks you have heard about circulating tumor DNA, which is a hot topic, I understand. But we'll chat about like what are like the downsides of it and also the pros of it. Part of the part of the surveillance, I feel, and I don't think we do as much as we can, and it's not because we don't want. It's just because, unfortunately, we don't have the capacity and we rely on either the family physician or other members of the team, like managing late effect, like side effects. So what I mean with this, what I mean is basically we know that there are like some issues with what we call, or now it's being called survivorship issues. Once you have finished your treatment, you can have certain side effects, lingering side effects from, let's say, the chemotherapy. Most of our patients will receive oxaliplatin and will have lingering neuropathy. What to do with that? The reality is that there are a few options, but that's where research should come to try to once we have been able to cure, then what we can do to improve quality of life beyond cure. I think that's really important. And we have to address the lingering physical impacts that our treatments have of on any person. So as you know, surgery, chemotherapy, radiation, all of them have lingering side effects and potential side effects. The reality is that this is a topic that is just getting more recognition as the time passes. There are like some clinics where there's the survivorship clinic increasingly being part of cancer programs, and I think that's the right way to do it. Um, However, in reality, as of today, as of 2026, the most of this heavy load is shared between the either the medical oncologist and the family physician. So it's really important that it's not the appointments for surveillance shouldn't be just like, oh, everything is negative, your CEA or tumor markers are negative, I'll see you in 6 months. It shouldn't be like that. It should be like, how are you coping with this, with lingering side effects? Is there anything that I can do? Can I refer you to a gastroenterologist probably to see if there's anything that we can do? Sometimes we might be able to help, sometimes fortunately, we are not as useful as we would want. Um, and the I think my main concern when we are in the surveillance phase is to try to restore the baseline quality of life. That would be my main goal. I think sometimes it's unattainable, unfortunately, given the potential side effects. However, it can be achieved in many of our patients. So when we look into why we do things as we do right now, the reality is that it has never been a clinical trial that actually has shown that this is better than not doing anything or comparing every 3 months versus 6 months or every year versus 2 years. The reality is that there's not a lot of data. Most of the data is what we call retrospective data. So that means like we didn't design the trial for that specifically, but we look into the outcomes of our patients. So we look into in retrospective what seems to be better, but the reality is that we don't have like really strong data on what should be the best surveillance strategy like that we have to do. And what is the standard playbook? The standard playbook for us, for all the oncology world, and I mean not only in Canada or not only in Ontario or whatever province you are in, it's also the States, the Europeans, and all over the world. We use these standard guidelines, which, as its name suggests, are only guidelines. Your physician, your doctor will always use their own their own thinking and on an assessment on whether or not you might need to do this like in a more intensive way or a less intensive way. The three guidelines that we usually follow are the Cancer Care Ontario, in my case, because I practice in Ontario. There are provincial guidelines that basically they are all the same, and they are actually based on the American Society of Clinical Oncology guidelines and the NCCN guidelines. So if you ever like have a question. And this is something that I know now that probably you already had a talk about, like how to use AI to help you to to actually answer some of your questions. And as you know, AI on its own can be dangerous because sometimes it will depend on what context you're giving to the AI, the response that you are going to get. Actually, there was a paper just published not long ago where actually the investigators, the researchers were able to make AI like recommend something that we all know as a physician community that it's actually harmful to the patients, that AI can actually will, if you like kind of corner it, it will tell you to do that. So just bear in mind. So what I do and what I normally recommend when anybody looks into AI, I always ask them to actually upload these guidelines and ask the AI based on only those guidelines and nothing else to give you like, oh, how my surveillance should look like. And then you can discuss that with your oncologist, and that makes a better way on framing it. So usually the clinical visits normally during the first year or two, depending on the stage that you were diagnosed at, if it was a stage one or stage three, it's normally stage one, stage two with low risk features. We see our patients every 6 months during the first year and second, or if they have any high risk, which is a stage two with high risk features and then higher, we see them every 3 months. And then once we get to the third year, everybody gets seen every 6 months. And the reason is because the bulk of recurrences happens within the first couple years. Then blood work. Usually we use the CEA or carcinoma embryonary antigen, but this has a caveat. This is a protein that is really, really unspecific. It can be elevated by diarrhea, by infections, by many, many things. And it only will be like useful if at the beginning of the diagnosis it was elevated. There are like some patients and disease and tumor in particular that don't produce any of it. So in those cases, it won't be needed. So most of the patients won't some of our patients won't even see it on their chart because if they didn't elevate it at the beginning, then it might not be needed. That doesn't mean that, we can added it to the blood work either way, but maybe the information that we will get from it, it's not going to be that informative. So, and then the CT scans. The CT scans, usually we do it every 6 to 12 months, depending on, again, on the risk. Remember that we do this with the intention to catch something early on. Okay. However, if we do find that these CT scans need to be done earlier, we can do it. Obviously, we have to be cognizant of the fact that some people might, repetition of exposure to radiation. Also, it's not a great thing to do. So we need to balance those risks. And colonoscopies also are part of the colonoscopies or even ileostomies are require baseline at 1 year post surgery, then 3 years, and then every 5 years. So that's the usual kind of a standard playbook. So we need to factor genetic situations here as well, which is how how your family history might impact also your surveillance. If you are considered to be a patient with a higher risk, like if you have any syndrome that increases the risk of colorectal cancer, name Lynch syndrome, Li-Fraumeni syndrome, or any of these syndromes that can increase that risk, then that's when we have to go far off and beyond. The standard guidelines are just a baseline, not a ceiling. So that's just take just take the guidelines and the recommendations that they come from as the minimal that you have to be put through and that you have to get. Okay, so that's just take it as the baseline. So hereditary syndromes completely change the playbook. And as I was saying, the Lynch syndrome, FAP, and Li-Fraumeni require some accelerated times. And in your case as coach, has your care team ever discussed any genetic testing with you, particularly for patients who have families with clusters of diagnosis with colorectal cancer or really early age diagnosis, they're like really it's really important to ask to, oh, do I qualify for germline testing? Like the meaning like could I have this? And that will not only have implications for you, it will have implications for if you have children, if you have siblings, if you're father, mother. So because those familial syndromes have a 50% chances of being transmitted to offspring. So it will be really important to make sure that actually doesn't get lost in translation. We already talked about CT scans. We talked about colonoscopies, CEA, and now the cutting edge kind of new technology that we are using. In the adjuvant setting, we had funding, at least in Ontario, until December. We got that cut out, which I'm really upset about it because I think it's not for everyone. I get that. And I get where probably the province is coming from. But also, I think there were like certain patients that really need to have the circulating tumor DNA. And as you probably know, this is expensive. It's $4,000 the first pop and then $2,000 every pop and afterwards, and it basically means that you would be paying like that every 3 months. So I don't think there's like many people who would be able to afford that. And I think these we need to create evidence in a clinical trial that these actually improve survival, which I think we are already working on it, but it's a working process. So for whomever who has not able to like read or know about the circulating tumor DNA, or what we call ctDNA, it's a highly sensitive blood test that it's looking specifically for tumor DNA fragments. It's basically a fancier, more specific, and more sensitive version of the CEA. That's basically how I try to explain it to my patients, and detects something that we call minimal residual disease. And it can detect these microscopic tumor fragments before a CT scan can even like show them. So obviously, that will change the risk stratification. Probably we would need to surveil like more often. And also it might, for some patients, because that piece of the ctDNA has been used to select whether or not some patients might require some adjuvant chemotherapy, some chemotherapy after surgery. But because here we are talking about surveillance, the reality is that we don't know. Okay, we found that. Then what? Then what's the next step? If we cannot see anything on the CT scans, on a PET CT, then what are we going to do with that? Are we going to start chemotherapy at that point without any symptom, without like any evidence of disease elsewhere? So that's where the hard questions about ctDNA comes because, and also then if I, as your physician, tell you, you have a positive ctDNA result. I cannot see anything on PET CT, MRI, colonoscopies, anything. So also how we manage the psychological weight of that with this evolving technology. So it's that's just food for thought. I think at the end of the day, it's really important to know that it exists. It's not part of the standard, at least not in Canada. I think it should become at some point once we have more evidence on how to use it. At this point, if you ask me, what would you do with a patient who has been undergoing CT scans and ctDNAs for the past 3 years? Because I have a few that are paying it out of pocket. What and I'm really honest with them, and I say like, okay, if this becomes positive and I'm not seeing anything anywhere else in your body, the reality is that I don't know what I would do. Like, could we chat about like getting you some chemotherapy? Yes, we can chat about it, but I think that would be unnecessary toxicity. That's my personal take on that. Uh, it might just make you feel anxious about a more potential progression. The important part of the ctDNA is that it has been able to predict recurrence up to in 100% of the patients who have it positive. So that's the main thing. That it's kind of a situation where we know that it will come back. We just don't know when. Some patients with a really good immune system actually are able to get rid of that. I have had patients with that being positive once, then at 3 months, negative. So what that was that? Probably it was the immune system getting rid of whatever cells, which can happen. Okay, so there's a lot of things that we can make from this. So I think that the most important piece of the survivorship and surveillance piece is the holistic survivorship. You have to you in this area and this juncture, you're reclaiming your health. Something important to remind you is that optimizing outcomes can be done through active lifestyle management. And not a lot of doctors talk with you about that. If you prioritize cardiovascular exercise, if you focus on whole food nutrition, and think about this, I'm not talking about organic, I'm not talking about like expensive. I'm just talking about whole food nutrition and decreasing the amount of processed foods that you're eating. That's it. It's nothing really magical. It's actually going back to basics. How I frame it. And if you maintain your bone health and muscle mass, that is going to do wonders. And I wanted to show you this because this is a trial that actually is quite interesting. It was actually, first of all, is a Canadian-led trial that was created by the Canadian Center for Clinical Trials in Kingston. We participated in this trial. And basically, they took patients who who already had resection for stage 3 or high risk stage 2 cancer, their colon cancer. And basically, they were randomized to either telling you like, oh, do it like eh, improve your lifestyle, your lifestyle, like in terms of the way I'm telling you right now, versus actually telling them, okay, you need to do 5 times a week, 20 minutes of aerobic exercise. Like that was the intervention. Nothing, that structure exercise program, it was only 20 minutes of basically making your heart rate being higher than 100 or up to the point where you started having a little bit of shortness of breath. So actually you were like a little bit winded. But there was like 889 patients. It was really well balanced. Median age was 61. So half of them went to the health education materials alone versus the actual program where actually they were followed and actually were put to do the exercise like for 20 minutes. And surprise, surprise, there's a 7% difference in disease-free survival without any other intervention. And if you look into what is that in relative risk perspective, it's exactly the same number that we get from chemotherapy in the adjuvant setting. Exercise. Just exercise, plain and simple. 20 minutes, 5 days a week. So since I saw that, I started doing it. So it's amazing how much exercise actually can do. And this is something that I think it doesn't get the attention that it needs. I never saw like or maybe I missed it, but I never saw like media posting about this. Like this is obviously this doesn't make money for any pharma company. This actually is really really amazing. Like when I tell to my patients, it's like, okay, this is something that you can do without the need of spending 1 cent. You just need to go out and take and do exercise for 20 minutes. That's basically how I frame it to my patients. And as you know, and I don't need to tell you all of this, but I just thought it was a good idea that I know that you guys and I appreciate all what you do for our patients. I know that your coach, your role as as coach is to be support. It's to be translators and advocates for the patients. And I appreciate all of that. And I wanted to give you a big shout out to all of you that you're taking time from your day to Philomena, to the whole team at CCRN, to the who are doing this, because with this we can help more people, we can help more patients. And also, I think that's something that I always tell to my patients when we finish kind of these, when we start the surveillance, is like, you're not my patient. You're somebody who's here for the surveillance. You stop using the word patient, because sometimes that change of framing it actually, yes, you are Filomena, you're Susan, you're Steve, you're Frank, you're Cassandra. You're Marcelino. You had to go through this. This doesn't define you. This is something that Susan had to go through. This was something that Steve had to go through. Your cancer, your disease doesn't actually define you. So you're just a Steve, you're just Susan, you're just Frank. Okay. So it's important to reclaim your identity again. Okay. So that's important. So just a couple words and I will be done. You don't need to be the oncologist. You're the guide there to support. You can help, you do already do these. You help peers to prepare concise questions. I think that's the main thing, like that you help them to prepare concise questions for follow-up appointments and trying to make sure with all the evidence that you have now, that all the knowledge that you have now, that something is not missing. Because I know that, and I can tell you from the medical perspective, I don't know any oncologist that wants to harm their patients. I don't know anyone. What I do know is that we are in a point in our healthcare system that is bleeding out doctors, that it's just overwhelming to have to deal with 50 patients in a clinic. I can make mistakes. And I'm the first one that I tell my patients, if you notice something that it's not going the way it was supposed to do, and I try to be as open as this, you're the safeguard. You have to be the advocate. So don't wait until I realize that something is missing. Is advocate for you and tell me if something is not going the right way. So I think that's really important. And that, no, I don't think any oncologist will take it, or most of the oncologists won't take it personal, will take it as thank you. I do think this is something really, really important, that we are a team. And I always tell my team, tell my patients, we are part of the team. We are trying to get this to the same goal. I'm the one who's just right beside you, but you're the director of this. So ownership of your care, it's really, really important. So encourage patients to own their schedule, their binders, digital files, making sure that everything is happening as it was supposed to be. If you see there's an appointment, because now with a lot of delays in our system, if your oncologist told you, I would like to get you a CT scan within the next couple of weeks, and you see that CT scan booked in 1 or 2 months, let your oncologist know, because I promise you that your oncologist doesn't get the notification when that is going to be done. We get the notifications once it's done, when it's resulted, but not before that. So own your schedule, own that part as well. And I think also part of your role is empowering the transition from patient back to person, which I think it's, and that can be done in the adjuvant setting, in the curative setting, and also can be done in the metastatic setting. You don't need to be cured to become a person again and not the cancer patient. Okay, because I think one of the worst things that this disease can do to anyone is rob them their identity. I think that's the biggest concern that I have when I have somebody in front of me is like, don't become your disease. You are you, and you're magnificent, you're beautiful. Just continue doing that. This is something that you're going through. That doesn't define you. So, with that in mind, I would like to open the floor for any questions, and I'm happy to answer anything. Thank you.
Thank you so much, Dr. Carmona. We greatly appreciate your kind words, both at the beginning and as well now. It's an honor, an absolute honor to support those that are in need, and especially in partnership and support of professionals like yourself. Thank you as well for your presentation, of course, and for your ongoing commitment to patients, caregivers, and of course, our cancer coaches. To our silent viewers, you can now head back to the lobby to join the next session, which will be at 12 o'clock Eastern Standard Time with Dr. Peacock after a small 15-minute health break. Our coaches will now head backstage for their question period with Dr. Carmona. We will see everybody at 12 o'clock.